This video will cover the diagnosis and management of stable asthma and COPD. By the end of the video, you'll be able to recognize a clinical presentation that's consistent with asthma or COPD. You'll be able to describe the criteria by which they are diagnosed, describe the systems by which they are staged, and last, choose an appropriate initial treatment regimen based upon that stage. First, let's compare the presentations of asthma and COPD. Who gets these diseases? For asthma, the age of onset is usually under 45, often but not always in childhood. In addition, patients with asthma will often also have either a personal or family history of something called atopy, which essentially means a predilection for allergies, which may manifest as things such as eczema or allergic rhinitis. For COPD, the age of onset is almost always above 45, unless the patient started smoking at a very young age or has a genetic disease called alpha-1 antitrypsin deficiency. So thus, anyone younger than 45 who presents with what appears to be COPD should be screened for alpha-1 antitrypsin deficiency. Also, the overwhelming majority, though not all, of patients with COPD are current or former smokers. While there is no sharp cutoff of cigarette use at which risk dramatically increases, it's uncommon to see patients with COPD having smoking histories of less than about 20 pack years. If you have a patient for whom you're considering a diagnosis of COPD, but their smoking history is a couple of cigarettes a day for a few years in college, you should consider some alternative diagnoses. Regarding symptoms, patients with asthma can experience cough, dyspnea, wheezing, and/or chest tightness, but these may only be present during exacerbations, also known as asthma attacks, which I'll discuss in the final video in this series. Patients with COPD also have cough and dyspnea, though they almost never are wheezy except during exacerbations. Instead, depending upon the severity and chronicity of the COPD, they can have various symptoms of right heart failure such as lower extremity edema and abdominal distension from ascites. Unlike patients with asthma, those with COPD are usually symptomatic between exacerbations. On exam, as with symptoms, findings in asthmatics are usually only present during exacerbations. In COPD, however, there are plenty of findings between exacerbations. Most often, medical students and residents mistakenly assume that wheezing is the most common physical finding in patients with stable COPD, but in fact, wheezing is usually not present. Instead, patients will have decreased breath sounds throughout all areas of the lung and have hyperresonance to percussion. They may have hypoxemia with or without cyanosis. Keep in mind that the presence of cyanosis is directly dependent on the arterial concentration of deoxygenated hemoglobin, which is, in turn, dependent upon both the O2 sat and the total hemoglobin concentration. So a patient with advanced COPD and chronic hypoxemia who becomes polycythemic, that is, has a higher than normal hemoglobin, can be cyanotic at a higher O2 sat than normally expected to cause such a finding, such as the low to mid-80s. Another finding is an anatomic deformity of the thorax called the barrel chest. There are two components to the classic barrel chest. One is an increase in the anterior to posterior diameter. In normal individuals, the thorax is much wider than it is deep. However, in patients with severe COPD who develop a barrel chest, the depth of the thorax becomes as great as its width. The other component of the barrel chest is kyphosis. Here is a lateral chest X-ray demonstrating both of these findings. Patients can also demonstrate pursed lip breathing. This is a technique that physicians or RTs teach patients in which they exhale unusually slowly through puckered lips. Although very simple, it decreases the dynamic hyperinflation that occurs with exercise in patients with COPD and has the net combined effects of decreasing the mechanical work of breathing and improving gas exchange within the alveoli. Another finding that can occur in COPD is a PMI, or point of maximal cardiac impulse, that is located in the subxiphoid location on account of hyperinflation and a relatively vertical orientation of the heart. The last distinction to discuss between the presentations of stable asthma and COPD is pulmonary function test findings. Asthma is characterized by variably abnormal spirometry, which is a quantifiable measure of lung and airway mechanics that can be performed either at the bedside or in a specialized pulmonary function test lab. Specifically, patients with asthma demonstrate low FEV1 to FVC ratios, a scooped-out appearance to the expiratory flow volume curve, and low peak expiratory flows. These are explained much more in my video series on PFTs, but here's a quick view of what this might look like on a PFT report. The FVC is listed here. This is forced vital capacity, which is a measure of how much total volume the lung can forcefully expel starting from maximal inspiration. The FEV1 is how much of that volume is expelled in the first second of forced expiration. And the ratio of the two is just that, a ratio. A FEV1 to FVC ratio of less than 70% is indicative of airway obstruction. The PEF is peak expiratory flow, which in this case is also reduced. And notice that there is a column for pre and post. That refers to pre and post administration of a bronchodilator, usually albuterol. In asthmatics, as a component of the variable nature of airway obstruction, there will usually be a significant improvement of these numbers following albuterol administration. And in contrast to COPD, occasionally spirometry may be completely normal between attacks. That can represent a diagnostic challenge if a patient's history is highly suggestive of asthma, but while in clinic, they are completely asymptomatic and with normal PFTs. In that case, something called bronchoprovocation testing can be performed. With this, the patient is exposed to some type of trigger that could cause bronchoconstriction, after which PFTs are repeated. If the patient reports in their history of some specific trigger, such as exercise or exposure to cold air, that's the best trigger to use for bronchoprovocation testing. This includes PFT testing before and after a work shift if an occupational exposure is suspected to be the cause of the asthma. If there is no specific trigger for the patient's symptoms, testing can be performed by inhaling a substance called methacholine, which is a cholinergic drug that stimulates smooth muscle contraction. With COPD, the hallmark PFT finding is persistently abnormal spirometry, which by definition includes an FEV1 to FVC ratio of less than 70%. Bronchodilators may cause modest improvements in PFT measures, but PFTs in a patient with true COPD will never be normal. So I've now thoroughly talked about the presentation of asthma and COPD, but what specifically do we use to diagnose them? I'm going to pull up this diagram from the first video in this series showing the relationship between asthma, chronic bronchitis, emphysema, and COPD. As I discussed in that video, these conditions all overlap, particularly chronic bronchitis and emphysema, and that having either or even both of those two isn't sufficient to be labeled as having COPD. You also need concurrent evidence of airway obstruction. This chart will also refer back to the first video. Asthma is defined as a chronic inflammatory disorder of the airways characterized by airway hyperresponsiveness to a variety of external stimuli, which results in episodic wheezing, dyspnea, and cough, and which is associated with variable airflow obstruction that is usually, but not always, reversible. From this, you can surmise that the diagnosis is made based upon the combination of symptoms and spirometry. Chronic bronchitis. We said that it was a chronic inflammatory disorder of the airways, resulting in a chronic productive cough and episodic wheezing. Therefore, the diagnosis is based solely on symptoms. Emphysema is a permanent enlargement of distal air spaces associated with destruction of lung parenchyma. Its diagnosis is based solely on radiographic evidence, such as CT. Finally, COPD is a chronic inflammatory disorder of the airways associated with incompletely reversible airflow obstruction, which is usually progressive and which is characterized by episodic exacerbations. Thus, a diagnosis of COPD is based chiefly on the presence of abnormal spirometry. However, by convention, patients must also have either chronic bronchitis and/or emphysema. If those definitions and diagnostic criteria feel convoluted and maybe even arbitrary, well, they are a little bit. The overlapping nature of these conditions make it not always possible to cleanly differentiate between them, but we still need common language to use when describing them. With all four of these diagnoses, however, it is critical to rule out alternative explanations. Since cough and dyspnea are very common and have dozens if not hundreds of specific etiologies, clinicians frequently focus on the wheezing aspect of these illnesses in order to identify them, which is problematic because wheezing is neither sensitive nor specific for either asthma or COPD in between exacerbations. There's a common saying in medicine, not all that wheezes is asthma, and not all asthmatics wheeze. This definitely applies to COPD as well, if not even more so. So when faced with a patient who is wheezing, one must run through in their mind the list of alternative etiologies for this. Etiologies of wheezing can be separated into different categories based on anatomic location. Extrathoracic causes, in which wheezing typically occurs during inspiration, include anaphylaxis, various forms of vocal cord pathology, laryngeal stenosis, and a goiter causing external compression of the airway. Intrathoracic etiologies affecting the upper airway include tracheal stenosis, tracheomalacia, tracheal tumors, mucus plugs, and a mediastinal mass. Last, intrathoracic etiologies which affect the lower airway include heart failure, bronchiectasis, bronchiolitis, aspiration, foreign body aspiration, some parasitic infections, in particular strongyloides and ascaris, Churg-Strauss syndrome, and something called allergic bronchopulmonary aspergillosis, which occasionally can complicate pre-existing obstructive lung disease from another cause. In my experience working with an adult population in the US, the most common causes of wheezing that can be confused for either asthma or COPD are heart failure or aspiration. In fact, wheezing that is caused by heart failure is called cardiac asthma and is presumably due to edema of the bronchial walls from high pulmonary venous pressure. I'm going to move on to treatment soon, but before this we first need to cover the staging of asthma and COPD. This is because recommended treatment for a patient is largely dependent upon what stage, that is, what severity of these conditions they have. For patients who are not currently on maintenance therapy for their asthma, that is, patients who are just on a rescue inhaler or on no medication at all, a system of 4 stages is used to categorize them. It's very common for clinicians to simplify the staging system and go solely off of symptom frequency, but it also includes baseline pulmonary function tests and frequency of exacerbations. Patients with so-called intermittent asthma have symptoms 2 or fewer days per week, their baseline PFTs are normal, and average either 0 or 1 exacerbations per year, which require the oral steroid prednisone. Those with mild persistent asthma have symptoms 3 to 6 days per week, normal PFTs, and an average of 2 or more exacerbations requiring prednisone a year. Those with moderate persistent have symptoms daily, a mild reduction in FEV1, and 2 or more annual exacerbations. And those with severe persistent have symptoms constantly, a moderate to severe reduction in FEV1, and 2 or more annual exacerbations. As you can see from the footnote, in general, the category or stage of asthma is assigned based upon the most severe feature. For example, if a patient has symptoms just once a week, normal PFTs, but has had 4 exacerbations in the past year, he or she is typically classified as having mild persistent asthma. The terminology doesn't make great sense because the symptoms in this case aren't actually persistent at all, but that's the terminology in use. And as I mentioned a minute ago, this staging system is used just for those patients not on maintenance therapy already. For those already on a good medical regimen, there is a separate system which I won't go over specifically, but it's very similar. For COPD, there are multiple different staging systems in use. Probably the most common system is that devised by the Global Initiative for Chronic Obstructive Lung Disease, also known as GOLD, which is based solely on the FEV1. Although it's very simple, unfortunately it's not very predictive of either symptoms nor risk of adverse events. To address this, GOLD subsequently developed groups which incorporate not just spirometry, but also symptoms and the number of recent exacerbations. Here's what this system looks like. Patients are first stratified by spirometry and frequency of exacerbations into low-risk and high-risk groups. And then they are further stratified within those groups based upon the severity of symptoms, which can be quantified using standardized questionnaires. This is obviously more complicated than the simple staging system based upon just FEV1, but it's felt to be significantly more helpful when making treatment decisions, which is ultimately its purpose. But be aware that unlike a staging system based solely on spirometry, With this system, patients don't progress from A to B to C to D in nice linear fashion as the disease progresses. Another system, one used specifically for prognostication, is the BODE Index. This incorporates a patient's BMI, airflow obstruction, severity of dyspnea, and exercise capacity. The patient is assigned different points for each of the 4 categories, with a minimum score of 0 and a maximum score of 10. And here is survival among patients with COPD separated out by BODE score. As you can see, a BODE score of 7 or greater is particularly predictive of poor long-term survival. So now we've finally reached treatment. When it comes to options for medications, there really aren't that many, and almost all are delivered via an inhaler, which delivers them directly to the airways and minimizes systemic side effects. First are short-acting bronchodilators. These are medications that work to relax smooth muscle in the airways. They work within minutes and have durations of action of about several hours. There are 2 categories. Short-acting beta agonists primarily include a drug known as albuterol in the US and salbutamol everywhere else. Short-acting anticholinergics primarily include ipratropium. Next are long-acting bronchodilators. These meds have onsets of action of minutes to hours and durations of action of anywhere from 12 hours to over a day. The more common long-acting beta agonists here include formoterol and salmeterol, while the only common long-acting anticholinergic is tiotropium. The last main category of meds are steroids, also known as corticosteroids or glucocorticoids. These meds work by decreasing airway inflammation rather than directly causing bronchodilation. Steroids can be inhaled, such as budesonide or fluticasone, or they can be taken orally, as with prednisone. Because these short-acting drugs have quick onset and short duration, they are colloquially referred to as relievers or rescue inhalers, with the idea that they are only used when actively symptomatic. The long-acting bronchodilators and inhaled steroids are referred to as controllers, as they should be taken on a regular schedule irrespective of whether or not the patient has symptoms at that moment, and should specifically not be taken on an as-needed basis. Understanding of this by patients requires face-to-face education and occasional reinforcement on subsequent visits. Last, systemic steroids should almost always be used just during exacerbations. There will rarely be patients with asthma requiring long-term prednisone, which is even more rarely done in COPD, but this should be an intervention of last resort. Systemic steroids have many long-term adverse effects, such as increased risk of diabetes, hypertension, osteoporosis, and an increased risk of some infections. Because certain combinations of medication classes are frequently prescribed, some drug companies actually produce inhalers or other delivery devices which include 2 medications together. For example, a combination of albuterol and ipratropium is marketed under the trade name Combivent, which is probably the single most common medication prescribed for COPD in the US. The combination of budesonide and formoterol is marketed as Symbicort, and the combination of fluticasone and salmeterol is marketed as Advair in the US and Seretide in many other parts of the world. As shown here, this combination is sold with a unique delivery device easily recognizable as a purple disc roughly the size of a retainer case. I'll now compare treatment recommendations for asthma and COPD side by side, and I think you'll appreciate some important parallels. Remember, in asthma there are 4 levels of severity. In intermittent asthma, with symptoms 2 or fewer days per week, albuterol or salbutamol, only as needed, is typically the only medication prescribed. Once a patient crosses into mild persistent asthma, a daily maintenance med is strongly recommended. First line is a low dose of an inhaled corticosteroid. However, an alternative to this is either a leukotriene receptor antagonist, cromolyn, or theophylline. Leukotriene inhibitors are not felt to be as effective as inhaled steroids, though compliance is believed to be higher. Cromolyn and theophylline are no longer common in the US, and further discussion of them is beyond the scope of this particular video. With moderate persistent asthma, the low-dose inhaled steroid is now a must and can be up-titrated to a medium dose. To that and an albuterol rescue inhaler is added a long-acting beta agonist. In this case, those uncommon alternatives can be used as alternatives for the beta agonist. Finally, with severe persistent asthma, in which symptoms are constant, the inhaled steroid should be a high dose, in addition to the long-acting and short-acting beta agonist. In addition, consideration can be given to the use of a medication called omalizumab, which is a monoclonal antibody against IgE. This is useful in asthma with a strong allergic component, but as with all therapeutics based on a monoclonal antibody, it is extremely expensive. And at this stage, chronic oral prednisone can also be considered, although as previously mentioned, this should be the step of last resort. COPD is also divided into 4 levels of severity, with recommended first-line treatments varying between them. The following recommendations are largely based on those from GOLD. In Group A patients, that is, those with mild symptoms and at low risk of an exacerbation, only a short-acting bronchodilator is typically necessary. While this can be either albuterol or ipratropium, in my experience it is almost always a combination of both as combivent. In Group B, patients are still at low risk of exacerbation but have more significant symptoms. In this case, a long-acting bronchodilator from either the beta agonist or anticholinergic classes is fine, in addition to as-needed combivent. In Group C, recommendations get a little more convoluted. Patients can be given both a long-acting beta agonist and inhaled steroid, or a long-acting anticholinergic. At this point, in addition to continuation of the combivent, a new drug that I haven't yet mentioned can also be considered. Roflumilast is an oral PDE4 inhibitor which reduces airway inflammation and can be used to help prevent frequent exacerbations. It's a relatively new drug, and experience with it is thus limited. And when patients reach Group D, you more or less throw the kitchen sink at them. In addition to all of the meds I've previously mentioned, some patients with frequent exacerbations, despite maximal medical therapy, are treated with prophylactic antibiotics, specifically a macrolide called azithromycin. This is a little bit controversial and not something I personally do, but there is some evidence that it may decrease the frequency of exacerbations. As with any medication, the benefits must be weighed against the risks, which with azithromycin include QT prolongation and selection for antibiotic resistance. In addition to medications, for Group D, surgical options can also be considered. These include lung reduction surgery, in which part of one lung is physically removed from the body in an effort to help improve lung mechanics. And of course, the most extreme treatment option for COPD is lung transplantation. So let's take a brief moment to appreciate the parallels between the management of asthma and COPD. First, treatment is based on severity of illness, and the severity of each is divided into 4 categories. In both diseases, those who are most mildly affected are treated with a short-acting bronchodilator as needed. In the second and third categories, there are similar drugs offered, specifically long-acting bronchodilators and inhaled steroids, though there is a greater emphasis on inhaled steroids in asthma compared to COPD. And in the last and most severe stage, patients are given a little bit of everything, including consideration of novel drugs such as omalizumab in asthma and roflumilast in COPD. And finally, there are a few general non-pharmacologic interventions to undertake. For both asthma and COPD patients, they should be advised as strongly as possible to not smoke, to avoid known triggers, and to ensure that immunizations are up to date, including the annual flu vaccine. And specifically for patients with COPD, a type of physical therapy called pulmonary rehab is helpful in improving exercise tolerance. And oxygen therapy for those patients who are moderately to severely hypoxemic will help reduce both symptoms and improve mortality. This reminds me of one final pearl regarding COPD treatment. While everything discussed will in some way impact quality of life, the only interventions in COPD that have been shown to improve mortality are oxygen, smoking cessation, and lung reduction surgery in carefully selected individuals. So there we have the summary of the diagnosis and management of stable asthma and COPD. The next and last video in this short series will cover the diagnosis and management of exacerbations.